We will now move on to the second plenary. It is my pleasure to now invite Professor Prasad Khatulanda, President-elect, Ceylon College of Physicians, Professor in Medicine, Department of Clinical Medicine, Faculty of Medicine, University of Colombo, and Honorary Consultant Endocrinologist, and Dr. Dumita Govindapala, Senior Lecturer in Medicine, Faculty of Medical Sciences, University of Srijawadhanapura, and Honorary Consultant Physician, Colombo South Teaching Hospital, on stage.
Thank you. Good morning, ladies and gentlemen. Our next plenary the topic is equity in healthcare. This is in keeping with the broader theme of the 57th anniversary annual sessions, the diversity, inclusivity, and equity. And also this highlights our great collaboration with the Royal College of Physicians, and this is delivered by Dr. Mumtaz Patel, acting President and the Senior Censor and Vice President for Education and Training, Royal College of Physicians. And she is a consultant nephrologist based in Manchester, UK, postgraduate associate dean for NHS England, and is currently acting president of the RCP. And also she has held many important positions in the Royal College of Physicians, and she has had a very distinguished and excellent academic research and a clinical career all along her career. Thank you very much. And let me invite Dr. Mumtaz Patel for the plenary.
Thank you for the warm introduction. Welcome guests, esteemed colleagues and friends. Lovely to be here with you today, and following on from Andy's talk, I'm going to talk more broadly about equity in healthcare. I've just realized that a couple of our slides may sort of be similar, but I think that's okay to emphasize the points again. What I'm going to go through firstly is that I don't have any declarations of interest to declare, so that's easy. And moving on, so what I plan to cover in the next half an hour or so is go through some of the key definitions around equity in healthcare, some of the principles around health equity, why is it important, what can be done about it, and how it can be achieved. A bit of a difficult topic to cover in half an hour. I mean, this could be a lifetime of work in itself, but hopefully I can give you some broad principles around this. And also exploring some of the barriers and enablers of achieving and sustaining health equity in different healthcare settings. And then what is the Royal College of Physicians doing in this space, particularly addressing health inequities? And I'll cover some broad areas around public health, gender equity, which is something very close to my heart, and also differential attainment. So kind of give you a bit of a broad flavour, looking at equity through different lenses. So I always start with a word cloud for those who know my presentations well. So it just gives you a broad overview of kind of the things that people think about when you talk about health equity. So is this around policy? Is this around systems, opportunities? Andy talked quite a lot around discrimination, race, ethnicity, age, lots of different factors. So a number of things come up when you think about health equity more broadly speaking. And a lot of things around disparities for people based on things that many times are not of their own making, of their own fault, and those kind of things that we'll just cover as well within the discussion. So thinking about definitions, the equity in healthcare is the idea that everyone should have that fair and just chance to achieve their best health. And it's based on those principles around that health inequalities are unfair, unavoidable, nobody's fault, happens, and there are things that could be done to address them. And as Andy pointed out, and you used a similar slide, equity is not the same as equality. Certainly when I came into this space many years ago, it's something that still troubled me, and I always like these kind of narratives as well as the descriptions to address that. So health equity prioritizes much more around social justice. It allocates resources based on need. And as Andy was putting down, the main outcome, I guess, is that you want to achieve equal health outcome. And when you talk about equity in that sense, you know, as Andy mentioned also, it's not just about access. You know, you could get access to healthcare, but then does it lead to the same treatment outcomes and same equal treatment for those who are of equal need? So when I talk about things as I go along, different people have different needs, and is the access for those the same? So I work in Manchester as a nephrologist, and even in Manchester, which is a very deprived city, there's different areas. So North Manchester, I would go to do my clinic, and the average life expectancy of patients there would be 60s, 66, I think. And then in South Manchester, which is quite an affluent area, I could do the same clinic, and I'd have patients in their 80s and their 90s looking really well and less comorbidity, and kind of again, it depends on different aspects which I'll go through with regards to determinants of health as well. So really important to kind of consider in a holistic way what you can do to help support. So in that kind of basis, health equity is very much determined by the conditions in which people are born, grow up, work, live, as well as their biological determinants. And again, something you don't always appreciate, whether it's your childhood experiences, your social housing, education, what access you have and opportunities you have at different stages of your life. And many of these things are not of your own making, but it's as a system, what can we do to better support as well? And again, looking at the importance around health equity, we think about the social determinants of health. So whether that's around some of the structural determinants, the social, the economic side as well, and then the system issues as well to kind of consider as well. So whether it's around housing, kind of employment, what people do, health literacy. Again, in Manchester where I work, I always get, kind of people give all the patients leaflets, but sometimes you don't even realize that many patients, a number of my patients can't read or write. And you think, gosh, kind of in this day and age, would you see that? And again, these are the things that we are challenged with, but it's kind of considering and looking at it from a wider lens to understand that these are real issues that people are faced with. And again, how can you better support them in that context? And what are the outcomes? So again, we know that the health outcomes are impacted with these determinants. So whether it's mortality, as I mentioned, about different life expectancy, morbidity, but also quality of life, and also healthcare expenditure, the wider functional status, so lots of different impacts at lots of levels, and important to consider wider that what you can do from a prevention stage to prevent a number of these things happening later to improve outcomes. So health equity per se is essential for promoting social good. And that's a key principle, as we know. And of course, it's linked to the social determinants of health, which I've tried to talk through. And health equity is a multi-sectorial issue. So it's not just about health care, sort of wider kind of social sort of settings, communities, and needing to think about it kind of broader on a public health basis as well. And like many things in medicine, health equity requires a data-driven approach. I always say data is really powerful if you use it to your advantage, but it's important to collect the right data. We've been submitting lots of data for our recent national reviews, but what is the right outcome data? Is the patient voice being represented? How we are looking at things, analysing things, but certainly data per se is very powerful. And health equity is a long-term goal. It's not something that's going to be achieved overnight, but small changes can make a big difference. And I think it's something feels like a mountain, but I think you have to start somewhere to try and achieve this. So you'll see a number of slides where I've put into kind of like different Venn diagrams, because I think none of these things can be achieved. There's no magic bullet that can solve everything. So when you think about what can be done about it to improve health equity, there's the systemic issues, the underlying systemic causes, and that's the fundamental causes of social inequities leading to poor health. Then in the middle, there's the community aspect, which are kind of around the social determinants of health. And then there's the individual person needs as well. So there's many things at kind of systemic, community and person, individual basis that you can address. And again, each of us can have a role in different sort of areas depending on our background and what influence we have to influence this and improve health equity broadly speaking as well. Looking at it as a stepwise journey as well. So health disparities we know exist in every single country all around the world, whether it's high-income countries, low-middle-income countries, it's there. And it's very much linked to these social determinants of health. In areas where there's, kind of more greater poverty, less poverty, wider kind of determinants, that affects the impact in slightly different ways. But sadly, it's there, to be addressed. And health equity, as we mentioned, is not just about access. It's more broader sense of following the patient pathway, patient journey, and prevention is key here. They shouldn't even get to the access point in a way if you do the prevention bit right. And achieving healthcare requires collaboration of a number of different stakeholders. So whether it's healthcare providers, policymakers, community organizations, so again, at different levels, and requires that multifaceted approach, and education is absolutely key. So even in my kind of practice in renal with a lot of diabetes patients and other sort of patients with multi-system diseases, education is absolutely key, and prevention aspect is key to then lead to better treatment and healthcare. So hopefully that latter pathway will be less required as well. And we play a crucial role in promoting health equity, social justice, and that kind of clinical competent, culturally competent care is really important. And I'll talk about that importance around leadership later as well in addressing social determinants of health. And advocacy is, again, a huge part of this through policy of advancing health equity as well, and different stages around that, as you can see. So firstly, around developing policies to address social determinants of health. And again, that's the responsibility of many of us working in healthcare to drive the right policies to then promote health equity. And advocacy as part of that is really important. Again, at different healthcare providers, policymakers can do this to advocate the change, promoting community-based interventions, whether you do that directly or the kind of wider team does that through education, serving underserved communities. Research obviously plays a huge part in informing policy, and that's a big part. And then fostering partnerships and collaborations, all these things, interlinked, but doing it in a systematic way to improve health equity. And then the social gradient of health inequalities. So I can't not mention Michael Marmot, a fantastic guy. I've kind of presented alongside him, always feel sort of very much imposter syndrome when you present against Sir Michael Marmot. So he did the big paper back in 2010 around this social gradient of health inequalities. So sadly, the people who have the less, and are more disadvantaged based on their socioeconomic status, sadly, the poorer their health is likely to be. So again, what action needs to be taken and how can they be better served, better supported in that kind of context? And it is unjust and it is unfair, and how can we systematically address that? So thinking that through, what's the RCP's role? So the Royal College of Physicians, as you know, and many of you who do work with me have seen my sort of strategy slides, but just one for today. So our broader vision at RCP London is very much, kind of improving healthcare for all in the UK, globally, and I guess we have different footprints in how we do that and influence that. And our mission statement is around educating, improving, and influencing. And improving health and care, a big part of that is prevention. Education is key to what we do, and it's kind of in the heart of what I do. And then the influencing, the advocacy, the kind of the broader support through stakeholders is a big piece of what we do. And again, doing this in a collaborative way, doing this with working with our patients, our partners, our key stakeholders, and having that inclusive approach and that diversity of thinking. And certainly when I was doing the global vice president role over the last sort of 3 or 4 years, that was a bit I absolutely loved, which was fostering that local, national, international networks, which is absolutely amazing, and trying to get kind of that diversity of thinking, but also that bi-directional learning from each other, which is hugely, hugely powerful. So from the RCP, prevention and health inequalities, prevention per se is one of our focus areas, 5 focus areas, and good health we know plays a fundamental role in the prosperity of our nation. As I was mentioning before, there's a 20-year gap in life expectancy between the most and the less deprived areas of England, and I see that just in Manchester, as I was explaining just before, from North and South Manchester, big 15 to 20-year life expectancy gap. And again, the complexity of disease, people projected to live for longer, but then with more complexity and more so from patients from deprived backgrounds as well. So we launched this Inequalities in Health Alliance back in 2020, and this covers 250 or so organisations convened by the RCP, and it campaigns for this cross-government strategy to reduce health inequalities and a number of different areas, whether it's housing, food quality, racism, discrimination, lots of different aspects. And looking at that socioeconomic duty, promoting the Equality Act, which looks at the underserved people, underserved communities, and more vulnerable people, and making sure their needs are met. Thinking about child health policies, and lots of learning from COVID as well. In COVID, those disparities were absolutely widened. We saw so much illness, so much death, morbidity, and mortality, sadly, in those who kind of probably were most vulnerable, and lots to learn from that and try and avoid for future pandemics, heaven forbid, but important to be prepared. And that programme of work continues with engaging with political stakeholders and that campaigning and influencing. And just in the next week, I think it is, the tobacco and vapes bill, we've been campaigning for that to reduce, making sure there's a smoke-free generation. That's one of the things that we've been campaigning for. Again, recently on junk food advertising as well for children. Childhood obesity is a huge problem in the UK. And then minimum unit alcohol pricing, something to learn from our Scottish colleagues as well for England, and working with government and key stakeholders to influence this. And just on Monday, I was in Brighton for our Liberal Democrats, so we're having all our party conferences as well. And we did a roundtable discussion at this conference with number of people from charities, from Royal Colleges, from different patient groups. And again, it was quite starking. Health inequalities in the UK costs us £5.5 billion. 1 in 5 people suffer from complex illnesses, and 80% of those are sadly from the most deprived communities. And our new government, so we've had elections back in July, and we've got a new government in place, and we've recently completed, there's been a big report looking at our NHS and what we can do, and prevention is a huge part of that and a whole nation approach towards it. This slide just summarises, and I'll share all my slides with you afterwards so you can look at it in more detail, but some of the barriers and the enablers around that, which was just from this discussion on Monday. And funding is always a huge issue. There's never enough money. Operational challenges are a huge issue. We're spending a lot of time on treatment, so we can't really focus on prevention side of things. Lack of joined-up care, health and social care, primary, secondary care, very little integrated care. And mental health, oh my goodness, 771 days for waiting to get mental health care, which is double the time from physical health. So much work to do. But what can we do to improve? So digitalization was mentioned, a wider system approach, a better integrated approach, safety management, seeing as a risk and thinking about the patient voice, particularly those with, who are more vulnerable, like patients with learning disabilities, autistic patients as well, and proactively engaging and educating. Diabetes UK had lots of great examples to share as well, routine physical health checks, and that focus on support of well-being of staff. I think we get forgotten along the way. I think, lots of impact on staff from, kind of probably still the moral injury from COVID, but also we're so pressured and need to think about the well-being of staff and retention as well as recruitment as well. So the national government-led approach, the 3 big shifts currently is moving healthcare from hospital to the community, analog to digital, and sickness to prevention. And we're delivering a mission delivery board to bring all these departments together to hopefully influence social determinants of health. And we've been promoting a much more cross-government strategy to achieve health equity as well. So lots of different things at a national government level. Thinking about equity in healthcare from different lenses, so we've talked a lot about public health, the social and the structural determinants of ill health. And I guess what the latter bit of my talk is around sort of gender gap, which I mentioned, something close to my heart, and attainment gap as well, some of the work that I've been doing as well as with the RCP. So inequality of women in healthcare, and I know Soumya, my colleague, is going to talk about more so broadly around leadership later, but just touching on the gender pay gap and different inequalities for women. So women earn less than 20% than men in healthcare and care sector workers, and that's kind of globally. Discrimination remains a huge issue. Over 2/3 of women experience some kind of discrimination, sadly, and that's been exacerbated during COVID. Sexual harassment is a huge, huge issue. There was big reports published last year. Over 90% of women have experienced some kind of sexism. Over half some kind of unwanted verbal conduct issue, as well as a third for physical contact. So lots of very sad issues, and at the RCP we've been doing a number of bits of work around sexual misogyny in the workplace and how to better address that. And then the gender leadership gap, which I'll just touch on with some of the work that we've been doing. So global women leaders challenge, over 70% of healthcare are women, but only 25% in high-income countries have senior leadership positions. When you look at low-middle-income countries, that number goes down to less than 5%. And again, academic roles, somebody like myself, again, very small numbers as well. Number of barriers and enablers in the middle that you can see. And things that we can do to improve is things around flexible working, formal policies around gender discrimination, harassment, and gender-specific leadership programs, which is what we developed at the RCP as well. And that need for change, we know it has a negative, the disparity affects health outcomes, not just for women and children, but in general as well. And it's a kind of achievement towards a sustainable development goal. So our Global Women Leaders program that we initially piloted in Pakistan and have subsequently rolled out in different countries was with that aim to achieve gender equity. And again, thinking about that different lenses, the individual, organizational leadership changes, and then system change. System and policy change is where we need to go. Nothing of this is about capability of individuals, it's how we can change the culture, the organizational sort of societal demands, and then how we can drive positive system change. So this program has been quite positive in achieving system change, and I guess it's sustainability of this over time that we need to achieve as well. And that kind of framework of achieving gender equity, again, on focus on individual, organizational, and enabling system change. So a bit like that individual, community, and system. So it's the same kind of principles, looking at it at different lenses as well. And finally, in the last few minutes, the bigger piece of work, again, I've been involved with over the last 7 years or so, is around reducing the educational attainment gaps. So differential attainment, a huge issue, unexplained variation of attainment of groups of individuals with protected characteristics, that those that don't have those protected characteristics. So whether that's gender, ethnicity, socioeconomic background, and looking at it from a fairness perspective is really important as well. And these things shouldn't be a barrier to achieving potential. And we know that different groups of doctors progress at different training levels. As we've said, Andy, it's not just about exams, but exams is where the differential is widest. So that's why, you always hear these kind of figures that UK white graduates in the UK have a 75% pass rate. Somebody like myself, born and bred in the UK, pass rates go down to 63% and 41% in international medical graduates. And again, lots of systemic issues, social, economic, cultural issues. Yes, there may be discrimination and bias, but we need to think about it in a systemic way. And looking at it, it's across the entire pathway. I've talked about exams, but it's from medical school, going into foundation year training, looking at the educational environment, which is absolutely key, and then progression, the kind of differentials become wider over time. Again, how do you think about it? So again, looking at it from the system perspective, so macro, meso, and individual levels, so you can think about national policies, processes, training time, and that's what I do in my college role. Then thinking about it from a deanery perspective, which is your local providers regionally. How does induction happen? How do we provide feedback? Diversity of the role models, that sense of belonging and inclusion is so important. And individually, what can you do as a supervisor? Making sure that you're adapting based on individual needs, looking at, kind of how you can support individuals and making sure that their holistic needs are being addressed. And that changing perception, moving away from a deficit model, it's not what, is not there from an individual, it's more an educational environment is so hugely important, and we need to shift that from an educator perspective of how we can better support our learners. So this has been a broad program of work over the last sort of 10 years or so, and cross-specialty work and evaluation of interventions is so important. And that focus both on trainers but also on trainee interventions is equally important. We need to support the trainers, to support the individual trainees, to provide better personalised support. And we've demonstrated that with a number of different interventions over the last few years, which have shown significant benefit, both from a quantitative outcome perspective, but also from a qualitative experience perspective as well. And finally, just about the importance of leadership and culture. Again, lots of discussions more recently in my current role through the college around the importance of leadership, culture, governance in all of what we do. So as public health leaders, we play a vital role in advancing health equity, and leadership is essential to that. And good leadership can do it well, and bad leadership, sadly, it can go the other way as well. And that's been consistently identified as a key factor in achieving health equity. You need to be able to care. You need to show empathy, compassion in all of what you can do. And we can change that culture. We can certainly set that culture. But also, I always say, even to my trainees and students, anyone can influence the culture, and it's being part of that change which is important. And cultivating that compassionate leadership, I think, if we've learned anything from the COVID years, this is something that we should take away, that kind of empathy, understanding, connection with people is so, so important to drive that positive change. So in summary, equity in healthcare is fundamental in achieving fair and good health outcomes. As I've demonstrated, it's linked to the social determinants of health. Focus on prevention is absolutely key. We need to think about it from a multi-level, multi-sector approach. Need to work at all those different levels. Data is powerful, as I've mentioned. Wide stakeholder engagement is key. Need to think about who our key individuals are that we're trying to influence and change. And as I say, sometimes it feels like a big mountain to climb, but even small actions can make a big, big difference, and that can lead to a bigger change. So just a few final thoughts to take away, but I always think these things are quite powerful, that we can all make a difference. Thank you so much.
Thank you, Dr. Patel, for that very informative and insightful talk. May I now invite Professor Prasad Katulanda, President-elect of the Ceylon College of Physicians, to hand over the token of appreciation and certificate on behalf of the college.